So I've been tasked with providing an overview of hypophosphatasia this morning in the next half hour. I don't have any conflicts of interest related to this talk. I'm going to provide you with a little snippet of history. We'll talk about what is hypophosphatasia. We'll go through the classification scheme. Then we'll talk a little bit in depth about alkaline phosphatase and how we believe it works. And then we'll talk about the nuances of diagnosis. We'll go on to talk a little bit about vitamin B6 metabolism. And then briefly, I'll mention treatment. So it was John Rathbun, a Canadian physician in 1948, that actually first described hypophosphatasia when he reported an infant boy who had died of acquired rickets. So he wasn't born with the rickets, but it was also complicated by seizures. And paradoxically, this little boy's ALP level was low. And it was thought of as paradoxical because most rickets, you end up with a high alkaline phosphatase. And in this instance, that wasn't the case. And then after the baby died, they actually looked in the bone and other tissues and found that it was low throughout. So hypophosphatasia is a heritable disorder, and it's the inability to put mineral, basically calcium and phosphorus, into the bones. In infants and children, we see it as rickets on X-ray. You can see it in the widening of the wrists, widening of the ankles. That's evidence, physically of rickets. And they also have soft bones throughout because there isn't enough mineral in the bone. Adults, once the growth plates close, you can't have rickets by definition. And adults have osteomalacia or soft bones, and that's where the name of the foundation comes from. So this is the classification scheme, the nosology that began in 1957 when it was first elaborated, and it's been expanded upon several times. It's based on the presence or absence of skeletal disease, and that simply differentiates odontohypophosphatasia from the other forms of hypophosphatasia. And then it's based on the age of diagnosis. And then it also matters what the severity of the disease is when we start distinguishing, as you can see here, the childhood types. There's a newly, when Dr. White wrote the nosology paper a few years ago, he distinguished a severe childhood from a mild childhood. And then the adult form is the next mildest, and then odonto is thought of as the mildest form without skeletal findings, but there are some caveats to that. Some of these kids do end up with craniosynostosis, so they do have some skeletal involvement. So the nosology is still a work in progress, really. And then most recently, the idea of the benign prenatal hypophosphatasia has been reported in the literature over the last 20 years, and we'll talk a little bit about that later. That adds a whole new wrinkle to the nosology. So the biochemical hallmark of hypophosphatasia is a low tissue nonspecific ALP, and you can see it in the literature as Dr. White likes to call it TNS ALP, and Dr. Milan and other people call it just TNAP, but both are the same thing. And it causes a generalized decrease in the alkaline phosphatase activity that we typically measure in serum or plasma. And again, it primarily affects the bones, leading to osteomalacia, rickets, and then fractures can occur based on how soft the bones are. And adults, it's not unusual to have a 50-year-old adult step off a curb not knowing they have hypophosphatasia and break a metatarsal. And then it heals. But then they step off another curve a few months later and break another metatarsal. And eventually they break so many they stop healing very well. There are several human alkaline phosphatases. So they're alkaline phosphatases because in the laboratory they're separated from the acid phosphatases based on the pH that they're analyzed in the lab, and we'll talk about what that can mean. But there's placental alkaline phosphatase that will be important in the benign prenatal story. There's also intestinal alkaline phosphatase that does end up in our total ALP measurements in the serum. And then less often germ cell alkaline phosphatase, which is often found in tumors and things. And then the fourth one here is the TNS-ALP that is most commonly seen in bone, liver, and kidney. It's also in the adrenal gland and in cartilage. Now, I don't want to frighten you with the protein structure of this molecule, but this is alkaline phosphatase. It takes two protein chains together to make the active protein. And here, one is shown in green, the other in blue. And then there are some metal ions. There's zinc and magnesium that are important for the conformation of the protein so that the enzyme actually works. And each of these chains, protein chains, can be made from either the gene you got from your mother or the gene you got from your father. So if there's an alteration in one, they can come together where you have a molecule that has both altered, one altered and the other normal, or two normal. And so if, depending on where the mutation is in the protein, it can alter, let's see, do I have a pointer here? So this is the crown domain, and some of the mutations here can disrupt the actual joining of the two proteins together, and then there can be mutations within the active sites that then don't allow alkaline phosphatase to work. And that's the general gist I wanted you to get out of this, that there's different ways these two protein chains can come together and end up with either active or some altered activity, and that'll be important later. So the natural targets for alkaline phosphatase are phosphoethanolamine, which was the first one found, and the idea is that alkaline phosphatase takes off this phosphate molecule here. So it's a phosphorus surrounded by 3 oxygens and a few hydrogens that make up phosphate. Pyridoxal phosphate here is the vitamin B6 vitamer that we measure in the lab to try and assess what your alkaline phosphatase activity is like. And then inorganic pyrophosphate here, 2 phosphate molecules hooked together, is the culprit that causes the lack of mineralization. It interferes with the incorporation of calcium and phosphorus into the crystals that need to be made. So how does ALP work? Well, it sits on the surface of the cell here, and then it's a phosphomonoester. So in each instance in the last slide, it just takes off that one phosphate, so monophosphor, and then the hydrolase is the fact that it can actually take it off of the other molecules. And again, the 3 natural targets are here. So inorganic pyrophosphate gets acted on, and then you end up with 2 phosphate molecules. The phosphoethanolamine, which is part of the anchor that actually holds TNS-ALP and other enzymes to the cell surface, it gets turned into ethanolamine and phosphorus. And then this is the vitamin B6 form, the active form PLP, that gets converted to pyridoxal and a phosphate molecule. Now this slide looks a little complicated, but this is how we believe mineralization starts. And so you have the monophosphate here that gets imported into something called the matrix vesicle. These are little kind of factories to make mineral in our osteoblasts, the bone-making cells. Calcium is also transported in, and when the concentrations get high enough, they start to crystallize together. And then they can make this kind of clump of crystallizing molecules that eventually they're sharp and they can pierce the membrane. And then from there, the crystals will grow and grow into the collagen and support the skeleton better. Pyrophosphate comes from all the phosphate molecules. Our DNA has a phosphate backbone. Energy in our cells is generated with adenine triphosphate, where a lot of the pyrophosphate comes from. And it can also be made by this other enzyme called ENPP1. But it inhibits this mineralization process. So what you see, this is an actual electron micrograph, and it prevents the calcium and the phosphorus from getting together and extending these crystals. So that's where we believe the inorganic pyrophosphate causes the problem. So how do we make a diagnosis of hypophosphatasia? Well, the most crucial thing is it needs to be made by a clinician. There's no single lab test that confirms a diagnosis. So we've got to take a good clinical history, try to determine if there was early tooth loss, determine whether there were any abnormalities detected in utero, were there bowed limbs, were there fractures. And then after birth, we often see failure to thrive. The kids can be weak. The kids may be working too hard to breathe and burning too many calories and fail to thrive. So there's all sorts of things we can glean from the clinical history. And then x-rays, diagnostic x-rays, and CT imaging may be helpful. A 3-generation pedigree is often helpful. Often when we see the first case, there's often somebody else in the family that didn't know they had hypophosphatasia. They just lost teeth early like the rest of their family. Or there's often been an early death in the family and often blamed on brittle bone disease, the severest form of brittle bone disease, OI type 2. We've had several families that came in thinking that a great aunt died of, OI type 2 as a baby, when we actually then were able to go test the family members and find out the 2 parents of that baby, now in their 80s, had low alkaline phosphatase levels, and that baby had severe perinatal hypophosphatasia instead. Dental problems in the family is always a clue, other skeletal deformities, delayed gross motor skills, and then, has anybody else been tested in the family? They started adding alkaline phosphatase to the comprehensive panel in about 1973. So most anybody who's had clinical testing, of their blood since then has an alk phos level we can look at. So hypophosphatasia can be inherited as an autosomal dominant disorder where it goes from generation to generation and it only takes a single altered copy of the gene. Or it can be inherited in an autosomal recessive fashion where each parent appears to be a carrier and then it only affects a single sibship. That would be characteristic of autosomal recessive inheritance, where the children each get 2 copies of the altered gene. And this is documentation from the nosology paper by Dr. White that shows that autosomal dominant inheritance is about 60% of the patients, and odontohypophosphatasia is almost all autosomal dominant inheritance. Mild childhood, similarly, about 70% is just a single gene that causes mild hypophosphatasia, while severe disease is the opposite. About 70% are caused by recessive 2 changes in the gene, so each parent carries an alteration. And then the infantile and perinatal, more than 90% of them have 2 copies of the gene to give them the severe disease that they have. On physical examination, we can see features that we recognize: a tall forehead, a wide round face, can often give us a clue to a diagnosis. An abnormal eye exam, if somebody has increased intracranial pressure, we might see changes in the retina. The ophthalmologist can actually detect crystals, calcium crystals, in the conjunctiva, the part of your eye that gets pink with pink eye. They can actually detect crystals there. And we have seen it present in people who have never been treated with Strensiq. So during the clinical trial, some of the kids developed conjunctival calcium, but we don't know if it was just the natural history of the disease or whether Strensiq actually contributes to that. We also look at growth, their stature, the bowing of their limbs, and then there can be neurologic deficits. So they're often with early onset from weakness and other problems. And then the most severe thing is vitamin B6 dependent seizures. When you look at routine laboratories, often they're normal. So a serum calcium, phosphate, vitamin D are not low like in most forms of rickets. In the severe cases, you can actually have hypercalcemia and similarly hyperphosphatemia, because you can't drive the calcium and phosphorus into the bones where it belongs. So more of it ends up in your bloodstream. And then it turns out with hypophosphatasia, for reasons we're not exactly sure yet, there seems to be a higher level of reclamation of the phosphate from the kidney, from when the urine is made. As it's passing through the kidney, normal people pull phosphate back out of the urine so that you can reclaim it and reuse it. And in HPP, it seems that even higher levels are reclaimed. So most kids with significant hypophosphatasia will have an elevated serum phosphate level. Now in the laboratory, we're looking at the tissue nonspecific alkaline phosphatase, and a low level is not diagnostic of HPP. There are at least 20 other diagnoses where you can have a low alkaline phosphatase level. Celiac disease, hypothyroidism, zinc deficiency, to name a few, okay? And the key thing to remember is that we're testing alkaline phosphatase at non-physiologic levels at a pH of 10. We have no idea how that alkaline phosphatase molecule works in our system at pH 7.4-ish. Okay, so if somebody has an alkaline phosphatase level of 16, which would be really low, I've seen parents with 16s who are totally normal. That variant of alkaline phosphatase may actually work just fine at a pH of 7.4, I'm sorry, but we're testing it in the lab at pH 10 to separate it from things called acid phosphatases that work better at low pH. So there's a lot of wrinkles in the diagnosis, and trying to determine, is somebody with a pH or an alkaline phosphatase level of 16, are they a carrier or are they affected? There's all sorts of nuances to that. We need to know their vitamin B6 level. We need to know how they've done physically to make the correct diagnosis and determine if somebody needs therapy. The other interesting thing is, if you look at the different variants, the mean level clearly decreases in alkaline phosphatase as you look at the severity. But if you look at any one individual, you can't predict what severity they have. Here are the individuals that went into making these bar graphs, and you can see there's overlap. Here's a child that ended up being infantile with a level that was comparable to somebody with odontohypophosphatasia. So it's not a straightforward diagnosis. Similarly, with vitamin B6, we see an elevation of vitamin B6, and that indicates that the B6 isn't getting into the cells where it needs to go. Alkaline phosphatase has to take off the phosphate on the vitamin B6 so that it can get into the cell as pyridoxal, and then the phosphate is added back to the PLP, and that's where it becomes active. We actually use this capability to test carriers and patients to see how effective their ALK-Phos is. If we give somebody that we think is a carrier 5 days of vitamin B6 and then test their blood, their vitamin B6 level will go up a certain amount. But an affected person, it'll go up much higher. But there are some people that are carriers that we give them extra vitamin B6 and they still have a normal level, okay? So sorting all of that out is crucial. So we get vitamin B6 in our diet in 3 forms: pyridoxal, pyridoxine, pyridoxamine. They're all converted in the liver to pyridoxal 5' phosphate. Then it travels through the blood bound to albumin, and when it gets to the target area where it needs to work, the ALP takes off the extra phosphate, the PL gets into the cell, it gets converted back to PLP, as I was saying, and then it's used as a cofactor for a number of other enzymes. Eventually, it's broken down into 4-pyridoxic acid, and then that comes out in our urine. So that's the pathway of how we use pyridoxal and pyridoxal 5' phosphate. And unfortunately, in this room, you're not going to be able to see this list, but these are some of the foods that the FDA publishes, amounts of vitamin B6 that are present in certain foods. So the top one is crude rice bran, which has 4 milligrams per 100 grams of rice. So just to give you an idea. Okay, the same thing that I commented about alkaline phosphatase levels corresponding to the severity of the disease. Here again, lower PLP levels correspond to the milder diseases. Okay, and you can see how high it can get with infantile. But when you look again at the individual cases, there's overlap. So you can't distinguish the type of hypophosphatasia strictly by PLP alone. Phosphoethanolamine was the first target that was found, I think, in the late 50s. It plays a role, as I said, in the structure of the anchor of alkaline phosphatase and other enzymes. It's not specific for alkaline phosphatase when it's elevated. Not always that useful for diagnosis, but it can be useful for looking at therapy, and also if there's vitamin B6 deficiency. We recently published a paper about a little boy, I'm going to show you some x-rays of later, who had perinatal hypophosphatasia, but a normal PLP. Didn't make any sense to us until we tested his mother, and his mother was deficient in vitamin B6. So he had no vitamin B6 in his system to help push it high and show us that he indeed had hypophosphatasia. The moment we restored his vitamin B6 levels to normal, they skyrocketed up. Okay? Inorganic pyrophosphate, we have been able to test in the past in a research laboratory. Alexion has an assay that's available, I believe, and I think Inozyme, another pharma company, is working to make it available clinically. The only way we can really access it right now is participating in the registry. And I'm in the process of getting enrolled in the international registry at WashU. X-rays are a key to the diagnosis and recognition of hypophosphatasia. Sometimes they're misinterpreted as Blount's disease. Other times vitamin D deficiency rickets, as happened to Cannon. But they're also key to differentiating severe and mild childhood disease. And that's a judgment call, but it's important because some of the milder kids may not deserve treatment with Strensiq. And then the other imaging modalities, head CT, MRI, can certainly be useful looking for craniosynostosis. So here's a image of a baby that was lost with perinatal hypophosphatasia. And I don't know if you can see any of the bones here. The clavicles are barely there. Their vertebral bodies are not all evident. And you can see how small this baby is. This is the umbilical cord clip, which is usually about this big. So sometimes there can be almost no mineralization. The lungs don't develop normally in utero because as the chest moves, the lungs form, and these babies don't have enough lung tissue to survive even if they were ventilated. We can see, lack of mineral in the cranium. Here you see a patient with milder disease where there is mineral. One thing you can look for on a skull film to make a diagnosis is the pulp chamber wider than it should be in the teeth that are there. So that tooth is still in the jaw, but we can see it, and that's part of the diagnostic information we can get from a skull film. Here are some milder kids with rickets. Can we turn off the lights down here? Just wonder if the x-rays will show up better. Huh? If we just turn them down. Does that help? Okay. So here we have changes in the metaphysis. The physis is the growth plate here, and then beyond it is the epiphysis. It's easier to see here in the knee. So this border here on the epiphysis beyond the growth plate is pretty normal in that you can see it discretely. But the metaphyseal region here is all chewed up. There's little spicules of mineralized bone, but this should all be mineralized here. So this is what rickets is. And here you see some small, what we call tongues of radiolucency, where the mineral isn't there, so the X-ray penetrates more than it ought to in that portion of bone. In terms of the genetics of HPP, the severe forms are thought to occur in Europe and in the US at about 1 in 300,000 individuals. In Europe, they've tabulated that the milder forms may occur at about 1 in 6,000. The changes occur in the ALPL gene on the chromosome 1, and there are now more than 400 mutations known to cause the disease in this gene. Most of them are missense mutations. Just a single change in the DNA code is enough to disrupt the enzyme. But there are some that are due to duplications of portions of the gene or deletions of the gene that can also cause hypophosphatation. Molecular analysis helps us find changes in the gene. But here again, finding an alteration in the gene does not give you the diagnosis of hypophosphatasia. You can be a carrier. We have people who have an altered gene that have normal physical findings, no dental findings, no biochemical findings, or very mild biochemical findings. And actually, these things can vary within a family. I'll show you an example where we have children where one was born with the same 2 mutations as his older brother, but he had infantile while his brother had childhood disease. So you really shouldn't be starting strensic therapy simply based on a molecular result or on a low ALP. You have to have a whole constellation of things together with a knowledgeable physician to really put the story together and justify treating somebody with strensic. We typically in St. Louis, have to find skeletal findings to start somebody on strensic. We have a couple of kids that had very mild childhood disease, never had a problem until they hit puberty, and then it seems with their growth spurt, they outstrip the capability of the little bit of alkaline phosphatase they have. They develop kind of a muscle phenotype and then have some problems with their bones that they haven't had before. So we have started some of the kids at 10 to 13 years of age on strensic, and they've done wonderfully. The adults often may have been missed as children having hypophosphatasia, and you'll see a 60-year-old adult who fractures a bone unexpectedly, and those patients certainly deserve to be on therapy, but you can't necessarily prove they ever had rickets. Then there are some newer ways. Etienne Mornay has come up with an assay to look at individual mutations in a system in his lab and determine how much activity they have. And let's see, the citation is here, but this is just a fragment. I had a little girl that was thought to have perinatal hypophosphatasia, born at 24 weeks. And what she missed out on was the last trimester of pregnancy when placental alkaline phosphatase kicks in. But she has a gene and an alteration that only causes includes 21% of normal activity, which might be enough to do okay most of the time. So in this assay, Dr. Mornay and his crew can separate out the single mutation. Then they can add in a wild type, a normal allele, and see how the two function together. And that gene, with the alteration with a normal allele, gives you 58% normal activity. That child is a carrier based on these studies. And she was on strensic for 2 years when she probably didn't need it. It probably helped her through the period when she was in the NICU growing to be a 40-weeker, but after that she might not have needed it because she's got normal, basically normal levels now after, you know, kind of half normal, but like somebody with odontohypophosphatasia. Okay. Treatment-wise, the first attempts at treatment by Dr. White at WashU were taking alkaline phosphatase from patients with, adult patients with Paget's disease who have very high levels of alkaline phosphatase in their blood. They gave that blood to a little girl, and, or they gave the purified enzyme to the little girl, and at first she seemed to get better, and then later on things kind of went south and she died of infantile hypophosphatasia. I participated in caring for a little girl from Ohio who got a bone marrow transplant, and she did pretty well. She needed a booster at one point, but this was prior to bone marrow transplant and then several months afterward, and she was healing. We've lost follow-up with her. Adult hypophosphatasia, patients may develop what we call pseudofractures. There's a thin little line here in the bone that can be very painful when you touch below your thigh. And Dr. White and Chad Deal treated this patient with teriparatide, an analog of parathyroid hormone, and that stimulates new bone formation, and she healed her pseudofracture. But the real revolution in therapy began with mouse models using a bone-targeted enzyme to treat the mouse model and prevent the mice from dying from severe hypophosphatasia. Human trials of that targeted enzyme began with aspartase alpha in 2008, and then it was approved as a commercial drug as Strensiq in 2015. This is just the title page of the original article in 2012, published in the New England Journal. And here again, can we cut the lights just to quickly show the x-rays? So this is a baseline x-ray. You can see all sorts of rachitic changes. Half a year later, 24 weeks later, the edges of the bone are, you know, nice and straight, easy to distinguish. And then even the shape of the bone, the modeling improves so that the radius here is noticeably thinner, and so is the ulna. So looking much more normal. Here's a baby's hand where there were no mineralized bones in the hand, and 24 weeks later, it looks like magic that all of a sudden all the bones are delineated. And lastly, similar findings at the knee, where again the modeling is abnormal, but most of the mineral has filled in, and then over time, this is at almost a year of therapy, much more normal bones. So the things to take away from this talk are that there are many nuances to the diagnosis and decision making that go into describing someone as having hypophosphatasia and determining whether they really need therapy. You really require a knowledgeable physician, the physical, biochemical, and molecular evidence, and you need to remember that no single lab value is enough to make the diagnosis. There are unaffected carriers in our population at 1 in 300 is the estimate, if you do the math. So we wouldn't, you know, hypophosphatasia doesn't occur in our population at 1 in 300. But there are people out there trying to convince physicians that every single person that has an altered gene deserves therapy, and that's really not the case. Even those that have hypophosphatasia may not need therapy. Odontohypophosphatasia patients don't really need therapy. There's no evidence that you preserve the teeth from falling out by giving them Strensiq. Okay? A lot of the development of the teeth goes on before they're ever born. So there are things that happen that Strensiq may not prevent. And then I will tell you personally, I believe I've taken as many people off therapy in the last 7 years as I've actually put on therapy. And I've had, patients with disfiguring lipohypertrophy that didn't ever really need to have received any of the injections. So it's a challenge every day, and there's a lot of misinformation out there about who needs therapy. And we have, endocrinologists all around the country that are prescribing this med, but I've had some instances where there's a misdiagnosis and patients get therapy and really shouldn't have had it. Don't even have hypophosphatasia. So I can tell those stories some other time, but okay. So I think we'll stop there with this talk.